I want to introduce Wendy, who's going to talk from her role as a liaison physician for Victorian Cytology service. So Wendy is a Melbourne GP who has extensive general practice background with a particular focus in medical education, women's health and sexual health. Her previous role includes a position as the Director of the Sensitive Examinations Program, the Department of Medical Education at the University of Melbourne. In her role as VCS liaison physician, Wendy provides education to GPs, nurses and other clinicians involved in cervical screening. Please welcome Wendy.
Good, thank you. So I'll just take this opportunity to remind everybody that VCS Pathology continues unchanged. A lot of people have been confused by the VCS registry, which is ceasing function, but pathology, we're still there at the end of a phone. So cervical cancer screening. This is just to put in to say how lucky are we to live in Australia. If you look down the bottom here, set to eliminate cervical cancer in Australia by 2028. The first country in the world. So we are so incredibly lucky. So for many years, we've had almost the lowest cervical cancer mortality in the world. And if we just counted Victoria, then we would always have the lowest cervical cancer in the world. We were also the first country to have Gardasil, so 2007. And because I think in large part to the incredible work that people like our clinical nurse Sarah doing with the Stop Anti-Vax network, or whatever they call themselves now, in Australia that anti-vax message is not as out there as in many other developed countries in the world. So it means that in Australia, we've actually got the largest cohort of HPV vaccinated patients in the world. And we've already shown that incidence or the circulating prevalence of HPV 16 and 18 has reduced by about 90% in our vaccinated and with herd immunity in that age cohort of women who've had access, and now men, having access to the HPV vaccine. We're the second country to implement a national HPV-based cervical screening program. And as I pointed out, we have an extraordinary coverage for our HPV vaccination. And some of you may be interested, we're currently the first in the world to be looking at the efficacy of the HPV screening pathway in a vaccinated community. So some of you may be interested in continuing to be involved in COMPASS. Now, I've put this up because it's a reminder, if we look at where we are, way down here, it's fantastic. But remember, many of our patients are coming from patients where cervical screening is just not on the agenda. They don't know about it. And so we have to be very mindful of that in our practices, that many of our patients from other countries around the world would have no idea what cervical cancer is, let alone screening or vaccination to prevent it. So I think as primary care clinicians, we have a role to remember we want to keep or engage all of our patients down that end and not let some languish up this end because we're not understanding where they're coming from and not explaining to them why it's so important. So you would all be well aware now that we've changed our cervical screening program to an HPV-based program. So our pap smear program has been incredibly successful, but international evidence really has helped us to understand the role of HPV in the development of cervical cancer, and around the world people or countries will be moving to that. So in Australia, about 93% of cervical cancer is actually due to the HPV strains, and I forgot to put in here that's in Gardasil 9. So as our young people coming through from 2018, 93% of the oncogenic HPV is going to be hopefully largely eradicated. But until they come, another 12 or 13 years till they reach screening age, we still have to remember that many of these HPVs are still circulating. Now, overwhelmingly, and it's really important that the vast majority of people, they have intimate contact, they will be exposed to HPV. But overwhelmingly, it's transient, asymptomatic, and it goes away. Now, in our language, unfortunately, as we've moved to HPV testing, it's suddenly hit home to everybody that, oh, it's a virus and it's transmitted by having sex. And it's women who bear the burden of being told that. And so I think it's very important in our discussion of HPV that we actually really normalise it for them and reassure them, because we at VCS are getting many younger and older women who are ringing us for advice because they're actually very distressed that they have got this STI. What are they going to tell their partners? How will they manage it? And so it's really important that we actually understand the impact that this is having on our patients in this transition period where people, it's new knowledge for a lot of people. Now, most low grades are a reflection of an acute HPV infection, and they just resolve. And that's why really for the majority of low grades, it's just transient. We don't really mind if we don't want to pick them up particularly. Importantly, by the time somebody is 20, it's estimated that about 50% of HPV infections that cause cervical cancer, they would have already been exposed. And by the time you're 30, you would have been exposed to about 75% of oncogenic HPV. But HPV only causes cancer in those women where it becomes persistent. And that also, people are thinking, particularly if they've got an HPV 16 and they're going off to colposcopy, they think they have cancer. So we have to be very careful of explaining. It's just while it's there, you may be at slightly increased risk. We're just going to monitor you until it goes. And in the vast majority of people, it will go. Oh, now before I go on to this one, we've just note over in that corner that the big one, 90% of women and men will be exposed to HPV in their lifetime. Now, the little paragraph under there I think is really important in that clearance does not necessarily mean that it's gone. Now, I've had chickenpox. Am I at risk of getting shingles? Do I know? Do we know, do some people clear chickenpox completely? Do we know? No. HPV is the same. So clearance means it's not detectable and not clinically relevant. It does not necessarily mean that it can't reactivate. And this is particularly important, encouraging people who are in monogamous relationships that yes, you're negative now, but you still need to come back in 5 years' time. And particularly the older women, and encouraging older women to come back for their exit tests. Now, who's still having problem with under 25-year-olds coming in saying, my mum wants me to have this test, she'll pay for it? Is that, yeah. So we've got a dedicated specimen reception person at VCS who rings clinics when we get an asymptomatic under 25 coming in for a screening test. And he says, do you really want this? Are you aware your patient will be billed? And many say, oh yeah, that's fine. So just remember, so I've put this up. This is a slide. This is post-Gardasil. Not Gardasil 9, the Gardasil 4. So these are just all the non-oncogenic HPVs. But if we look at this group here, so HPV 16 circulating at around about 1.5%, 6, 11 and 18 incredibly unlikely. But look at all of these. These are all the others. So these young women, it's almost normal that they will be positive at some time. And this is why it's really important that you actively discourage them, because there's also acute HPV infections can sometimes cause what looks to be high-grade change. And there's a recent international study at which the Royal Women's was also involved in, that shows that a significant proportion of women with high-grade abnormalities under the age of 25, they resolve without treatment within 2 years. Now, if your 19-year-old's got an acute HPV infection, has a high grade, goes off, has a colp, shows they've got a high-grade abnormality, they may well be treated. Now, if they then get a further infection in their 20s and get another high-grade abnormality, they may be treated again. And this is where you're looking at increasing risk of obstetric complications. So please don't let them do it. Say, you don't want to do it, it doesn't matter. So you all know this. New screening starts at 25. If you're negative, come back in 5 years. Exit test is now 70 to 74. The first test is the HPV test, testing for 14 oncogenic HPV. And that's what we call the CST. Now the CST also includes a reflex cytology, so they'll do a cytology on any HPV positive test. Now, symptomatic women can be tested at any age, requesting a co-test and documenting the clinical symptoms. Now these other, and particularly remember, pregnancy is not a contraindication to screening. And early onset sexual activity, I've put that down. A lot of people are very anxious about this. There is a little subset. If a woman became sexually active under the age of 14 and before Gardasil, they are eligible for, or they can have one HPV test between 20 and 24 years of age. There is no evidence to say that they're in increased risk, but there is no evidence to say that there are not. And so it's a reflection of some women may be very anxious about this, and you can offer it to them, but you do not go and need to case find. Now, I'm sure by now you all are very clear with what the renewed pathway is. Just a couple of things to remind you. If an HPV 16 or 18 is detected, the reflex liquid-based cytology is not to change the recommendation. It's to inform the colposcopist. And so people with an HPV 16 or 18, they are referred for colposcopy irrespective of this cytology. And there is a lot of confusion about that. And so it's very, very important. You don't think, oh, cytology negative, that's fine. If the colposcopist sees that there's high-grade changes or glandular abnormalities that they then don't see at the time of colp, they will look much harder. So it's to advise them, it's not to change the recommendation. So unsatisfactory, if there's an unsatisfactory test, repeat in 6 to 12 weeks. So if the HPV test is unsatisfactory, you still don't know whether you're going to need a reflex cytology or not. So make sure that you allow for the possibility that you're going to need cytology. Wait for 6 to 12 weeks. Now, if there's a reflex cytology with a non-16-18 and it's unsatisfactory, again, retest that in 6 to 12 weeks. Please only ask for a follow-up liquid-based cytology. If you ask for a CST or a co-test, your patient will be billed for the HPV component of it. They only need the LBC. Now, I've put this slide in because people, and in explaining to our patients, they've got a high-risk HPV. So, if they've got HPV 16 or 18 at baseline, over time, if it persists, their risk of developing a high-grade abnormality is significantly increased. Whereas if they've got a non-16, 18, over time, it's sort of, yeah, you've got a bit of a risk, but nowhere near as 16 or 18. So they're the intermediate risk. And if you don't have HPV, then your risk is extremely low. And that's why there's this partial genotyping, and we treat the 16 and 18s differently. So it's a risk-based approach. It's also taking into account their screening history and what you're putting on the clinical notes. Now, this screening history may be causing a few of you grief at present. So all of those women who've had their historic high grades treated in 1990 and they've never had their test of cure, they're now coming in with these really scary letters from the NCSR saying, I've got to have this test. You know, because you told me my HPV was negative, but now I've got a reminder, and it's because they've not completed their test of cure. And we know that women who had a previous high grade treated, they were at increased risk of getting recurrence, sometimes decades down the track. And we know that was because they were the women who did not clear their HPV. So just be aware that many of these women won't even remember they've got a past history, and you may not know it as well, but they'll be coming in, so check their history with the NCSR. So the HPV test is a test of risk. The reflex LBC is our triage. We then go to colposcopy, and that is to tell us is there disease. The co-test is only in a symptomatic woman for test of cure in women who've been previously treated or surveillance. So I was just going to briefly go through how do you take an effective CST. So one of the important questions is, do you still have to sample the transformation zone? Now, many of you would be aware we can now do HPV self-collection, so why do we need a cervix? Now, we need the cervix because that reflex LBC, so we don't know, is our patient going to have an HPV positive test result? We don't. So we have to take all our samples with the assumption that she may be HPV positive, because your sample will then be triaged for reflex cytology. So if you've got an HPV non-16 positive woman and you sort of think you got somewhere near the cervix, how reliable is that triage going to be when you're determining, will she come back next year, or will she come back in, or will she be referred to COP? So it is actually still very important. And just a reminder that the transformation zone can, in young women particularly, be quite far out, so you really have to take your instrument a long way out. Now, HPV unsats are much less than cytology. We need far fewer cells, but we still need cells. And the biggest reason for not getting cells or an unsatisfactory are due to low cell count. And 10% are because the lubricant globs with the cells, and it means that they're effectively insufficient cells. So when we're using lubricant, well, ideally using lukewarm water. If you do need to use a lubricant, only use no more than a 5 centimetre diameter size on the outer part of the speculum, avoiding the tip. Now, with your vial, make sure that you use 3 identifiers. So it's a NATA requirement. We get lots of people saying, why has my report come back with mislabeled? And it's because you have to have a first name, a last name and a date of birth, which are on the request form as well as on the vial. So you can't have Kay Smith on the vial and Kathy Smith on the referral form. You will be rung by our lab and asked, are you happy for us to authorise it? And if you say yes, you will get this is mislabeled. So we cannot process it if they don't match. Now make sure you seal it correctly. And when you're using the instruments, you really have to be, you really have to be very vigorous to make sure that the cells come off in the, so if you're using a broom, you're going squish, 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 squish on the bottom and then vigorously agitating. If you're adding in a brush, rotate it, pushing against the wall of the vial and then agitate. And we've just got a couple of, you need to check with your lab what they're happy with. We know L-Gel and Applicare, which are some of the common ones, have carbomer, and they're the ones most likely to glob things up. And just referring to stats before, we need to know who we are screening so we know who we're not screening. So please, please fill in these details. It is incredibly important that we have that information, because then if we know there are certain target groups in our population who just rarely are screened, we will be able to work with those communities to develop culturally appropriate ways to engage those people. Now, there's lots of angst about exiting the program. We've had probably lots of your patients are coming in with their reminder or overdue letters saying they're now overdue for their cervical screening test. And they say, but you told me when I was 70 I could stop doing these. And it's because we now have better knowledge of the natural history of HPV, and we know that a woman who's aged between 70 to 74 who does not have HPV detected, her risk of developing cervical cancer in the next 10 years is incredibly remote. And I put this up because many patients who are ringing us and saying, my doctor said I don't need to do this, or the doctors are ringing and saying, oh, look, she really doesn't want it because it's pretty uncomfortable and what have you. Most of them, if you say the second peak of cervical cancer in Australia is 80-year-olds, and then I talk about chickenpox and shingles, and most of them have just had the shingles vaccine, and I say HPV can reactivate. So as your immune competence declines when you're older. And so having an exit HPV test if you're negative is incredibly reassuring. So hopefully we get lots of questions about that, and I think it's really important to understand why we need to encourage these women who are coming in and saying, oh, well, you told me I didn't need it. And just a reminder, we are so lucky, but it requires the ongoing support of all of these organisations and primary care clinicians to make sure that we reach that target of cervical cancer eradication by 2028.